My presentation is on a functional medicine approach to autoimmune disease with case studies. And these are my disclosures. I'm the Director of Product Development, Research, and Clinical Support at Designs for Health. And for the last 7 years, I've been an adjunct clinical instructor at University of Bridgeport's Masters of Nutrition program, where I've taught functional medicine nutrition, nutritional therapeutics, and helped out with other instructors with the virtual clinic. So what I really want to discuss today, I'm sure there's a bunch of practitioners that have different levels of functional medicine training, and I want to try to give as much information I can in an hour about if you have a lot of experience with functional medicine, maybe you get a slightly different lens on how you look at some of your patients, but then also if you're really new to functional medicine and nutrition, some different nutritional therapeutics that you can consider for your autoimmune patients. So we're going to cover some of the different environmental factors that contribute to autoimmunity, recognize the role of clinical laboratory testing to assess autoimmune dysfunction, how we can assess digestive function, mucosal immunity, and gut inflammation, and then how do we determine different dietary interventions and nutritional therapeutics for patients that have autoimmune disorders. So this is a couple figures out of Yeshanda Schoenfeld's book. And I just want to mention briefly about the development of T cells. A lot of practitioners, we will test these autoantibodies for either predictors of future disease or for the diagnosis of different autoimmune conditions. And those are typically going to be produced by your B cells. And they don't really indicate the severity of the disease, but it's really the T cells that either release pathogenic cytokines or there can be impaired function or excessive expression of them. And we have our T cells, our double negative T cells, our T regulatory cells, Th1 cells, Th2 cells, Th9. I'm briefly going to talk about some of the Th17 cells, and then we have our T follicular helper cells. So realistically, what happens with patients with autoimmune is they typically have multiple triggers that are chronically stimulating the immune system over an extended period of time in multiple ways, and our immune system gets overloaded, overwhelmed, and it loses its ability to function. So this is a figure out of one of Yeshanda Schoenfeld's book, or one of his articles. It's also in his book, The Mosaic of Autoimmunity. But it really talks about these endogenous and external factors that play a role in autoimmunity. So we can't change the genetic predisposition, the gender, but it's our job to kind of go down a rabbit hole, essentially, of trying to figure out what are the handful of things that is having dysfunction that we can address, whether that's vitamin D deficiency, vitamin D polymorphisms, gluten intolerance, food sensitivities, nutrient deficiencies, hormones, dysbiosis, infections, toxins, etc. So the challenge is, as an alternative practitioner, I'm not going to replace someone's primary care doctor and specialist, and I'm not going to treat any of these conditions. It's more of, I'm going to take a snapshot of your physiology that your doctors are not looking at, see where that physiology is not functioning normally, and then we're going to bias these things with dietary, lifestyle, and nutritional therapeutics. And I think the frustrating thing is there's a time and place for a lot of these medications potentially for autoimmunity, but none of the doctors treating autoimmunity are telling their patients that they can change the trajectory of their condition by making dietary, lifestyle, and taking nutritional therapeutics. And if they would know that, then I think a lot of people would be interested in it. So this was an article in Scientific American back in 2007. And it was really looking at autoantibodies as a predictor of future disease. So how many people in this room test antibodies regularly on your patients just like you would do like a CBC, metabolic panel, lipid panel? So most of the people are familiar with this. I mean, obviously, the interesting thing is, I mean, this is just an example with rheumatoid arthritis. But when rheumatoid factors positive and CCP antibodies first positive, they're asymptomatic, right? It's preclinical. So it's very similar to Hashimoto's is another example. Like the TPO antibody will become positive 7 to 10 years before they have TSH that elevates. So traditional medicine will say you have a positive antibody for hypothyroidism, but you don't have hypothyroidism. And the reason I really chose to present on this topic is it's really a personal thing for me because my grandmother had rheumatoid arthritis. My dad was diagnosed with rheumatoid arthritis. And when I was 20 years old, I went to a doctor and they told me I had positive antibodies for hypothyroidism, but you don't have hypothyroidism. And they said, you appear to be fit and healthy, and everything was dismissed. So when we look at different things that we can test, I mean, these are just examples of a few labs that do antibody screens. Obviously, you can use traditional labs like LabCorp and Quest. And then I put this one study in here that looks at intestinal health in human health and disease. And if you look at the picture on the left, you can see that the things that impact this intestinal barrier, such as high-fat diet, dysbiosis, alcohol, medications, etc. And it doesn't just contribute to autoimmunity, it contributes to a lot of other chronic diseases. But on the right, you can see the small intestine. And in the outer layer, you see the dietary fibers and the microbiota. And then in the middle layer, you can see the secretory IGA and the mucus layer. And some of the bacteria you see that make up the mucus layers, one of those is Akkermansia. And then when you get to the inner layer, you have your epithelial cells, and then your innate immune system, and some of those immune cells. Now, the interesting thing is the stomach and the colon have 2 layers of a mucus layer. The small intestine only has 1. So the commensal bacteria that reside in the small intestine actually make contact with the villi, where in the colon they don't. So they're more predisposed because that's an area where there's nutrient absorption. So this was a study in 2014 that looked at intestinal barrier dysfunction in multiple sclerosis. And the interesting thing, if you can read here, was talking that the one doctor said he believes that future drugs to treat MS should not only focus on the central nervous system, but also on repairing and restoring the intestinal barrier. And I don't know any neurologist that's seeing patients for MS that's doing stool testing or intestinal permeability screens on their patients. So it's a perfect example of the disconnect between what you see in the medical research and what we see in clinical practice. This is just an example of how you can assess the intestinal permeability. A lot of times, probably 10, 15 years ago, most people were doing more urinary type testing for this, but there's a lot of immunology labs out there that can look at antibodies to different proteins such as zonulin, actin, occludin, LPS, and then a lot of the stool panels these days you can add zonulin on in the stool. And then here we have a study on looking at the relationship between autoimmunity and diet. And the interesting thing is when you look at all these studies on diet, they're always comparing a Western diet to a Mediterranean diet. There are diets out there that people may follow for autoimmunity, but in all honesty, the reason I put this in here is it's going to be individual to every person, because a lot of the diets you see that are marketed for autoimmune, they're very restrictive. They weren't designed to be a long-term strategy. And when you're promoting those things to the masses, it has to work for 80+% of the people. So it has to be extremely restrictive. And a lot of these people have a fear avoidance of what they can eat anyway, and then you end up with micronutrient deficiencies and other things associated with it. So although I've had mixed, I guess, opinions on food sensitivity testing over the years, I do think they've come quite a way in their technologies, and what they do is they can act as a tool, where people are eliminating processed foods and they are eating things that they're not eating every single day that they were potentially reactive to, and they tend to do better. So here's another article by Yashanda Schoenfeld, and this talks about some of the different dietary factors in rheumatic autoimmune disease. So what I would say with some of the nutrients in the next few slides, even if you're not doing any testing at all, we can be optimizing people's essential fatty acids and curcumin. There's obviously not really much safety issues with dosing the curcumin. I will say my experience doing omega checks on everyone, most people have around a 3.1 to 3.5% omega index. And to get that to around an 8%, it's around 3 grams of fish oil. And when you're looking at a lot of these, I would say 5+ years ago it was a lot more expensive to do a fatty acid profile because you had to go through a specialty lab. But now, I mean, if you can have client bill accounts with Quest and LabCorp, I can run an omega check for $15 through Cleveland Heart Lab. So it's very inexpensive to do that, and we can optimize it for all of our patients, specifically even the ones that are taking fish oil, because a lot of times they're buying a soft gel that's 1,200 milligrams. It's an 1812 oil, and when you look at the back of it, it's 320 milligrams of EPA and DHA. To get that 3 grams, they got to take 10 soft gels. Where if they take one of the professional brand products, they can take 3 to 4. So interestingly enough, when you're looking at coffee and salt here, coffee can be an issue with rheumatoid arthritis, and it's really dose dependent because it affects the efficacy of methotrexate. So just something to keep in mind. And then looking at salt intake, I know there's a lot of controversy with salt. I mean, there's books just on salt written out there promoting lots of things, but I would say specifically sodium chloride, what you see in a lot of processed foods, is potentially going to exacerbate your Th17 cells for these patients. Has anyone seen this VITAL study published last year? So they did a study looking at vitamin D and fish oil on autoimmune disease, and they showed that vitamin D supplementation for 5 years, with or without omega-3s, reduced autoimmune disease by 22%. And if you add it with or out the omega-3 fatty acids, with or out vitamin D, it was 15%. So if you do a combination of both of these, we could probably mitigate some of this by around 30%. The only thing I don't like about it is, I don't like when I see these studies where it's always 1 gram of fish oil or 2,000 IU of vitamin D or 600 IU of vitamin D. Sure, it's going to prevent a true deficiency, but we're not getting an optimal dose. So I would speculate even if we could get a higher percent based upon that. And this was a study published last year that I like because it's the first study that I've come across, and I do PubMed searches every Monday for nutritional therapeutics and human studies, and they showed that getting to the 40 to 60 nanograms per ml was optimal was better for optimal health. And most of the time, these studies are just looking to get to 30. They're just trying to get into that lab range. So there was also a study in the journal Immunology in 2014 that showed the maximum anti-inflammatory effect and immune modulatory effect happened at 50 nanograms per ml. So that was my 15-minute intro on what I wanted to cover with some of the environmental factors that a lot of us are aware of, some more recent studies. But I'm going to spend the last 40 to 45 minutes. I'm still going to talk about nutritional therapeutics, but I'm going to walk you through 4 cases, provide the studies, how we worked them up, what we did, what the outcomes were. And then this way you can decide if some of these things you could take into your practice. And obviously I may have a personal bias to some of the labs I use, but I will say I have no affiliation with any of the labs I use, and all the labs that I use besides the traditional labs in this presentation, they're all here at the show. So you guys can look into, if you have an interest in any accounts with them. So this was a patient with rheumatoid arthritis, 51-year-old female. She was diagnosed with RA in 96. So she's had, when I saw her, RA for about 20 years. She was previously taking Plaquenil and Celebrex, and they weren't really helping with her symptoms, and she was currently taking Enbrel at the time when I saw her. So she's following the standard of care, but she's still symptomatic. So what are these people supposed to do at that point if they don't really go down their own rabbit hole of looking for someone who does functional medicine? It's not like they're trying to avoid taking the medications, they're just not working. So in her case, we did a multi-panel and a stool test. I mean, I put the food antibody test on here as far as a recommendation, but we didn't end up testing that. But you can see this is just a snapshot of her original stool test. And this is a QPCR test. You can see that she had some pathogenic bacteria that were out of range, some dysbiosis markers, some non-pathogenic parasites elevated. But I think the big take-home and why I like stool testing is not necessarily for the pathogenic stuff on the first page, because a lot of those things can be self-limiting, and a lot of times traditional GI docs can test for those as well, even though they're not tested a lot. But when you're looking at where these really, I think, shine is looking at the intestinal health markers and the other dysbiosis markers, because you're getting a snapshot of how the GI is functioning. And then you get to see digestion absorption markers, immune and inflammatory markers, markers around intestinal permeability, and potentially gluten sensitivity. So it gives a good snapshot there. It's very easy to, when you have a patient sitting across from you, to educate them. And then it gives you a targeted approach, because there's certain commensal bacteria that are not going to really get elevated with your normal traditional probiotics, and you're going to have to look at polyphenols, prebiotics, dietary fibers, etc. So this was a study just looking at the role of intestinal dysbiosis in nutrition and rheumatoid arthritis. This was published last year in 2022. And big take home here is just there's dysbiosis in autoimmunity, and we talked about that mucus layer, and we typically see lower amounts of Akkermansia and FPROV. So we also did on the multi-panel, you can see on the organic acids that there's some abnormalities here. How many people here use organic acid testing? So we got maybe about a third to 40% of the group. So this is just the snapshot of the bacterial metabolites. And so when you do a stool test, you're only looking at the sigmoid colon, right? That's the compartment you see with the stool. When you're doing an organic acid test, you're mainly seeing at least the bacterial metabolites, somewhat of a snapshot of the small bowel. I mean, obviously, you're looking at upper GI or small bowel. You can also consider things like breath testing. But in this case, we see indican high and the D-lactate elevated, which we typically associate it with protein maldigestion, carbohydrate maldigestion, possibly dysbiosis. You can consider an enzyme here. We might consider antimicrobials. But one of the big things, especially since D-lactate is outside the 95th quintile, I'm probably going to avoid lactobacillus probiotics. Or if I gave someone a high-potency probiotic, they're probably going to have an issue, or those are the kind of people that get bloating with it. So if I go back to her profile, on her stool test, she had lactobacillus that was low. And here's where I'd make the exception and be cautious, and I tend to use something more like Sac Boulardii in that case. So when we started on a strict gluten-free diet, avoiding processed foods, obviously. We did an antimicrobial blend. So this is your gram-negative cytyl-type botanicals that is relatively sparing to the beneficial bacteria that we're going to use therapeutically for 4 weeks. And then we'll combine it with a digestive enzyme. And then most people think of Sac Boulardii as just for traveler's diarrhea or during antibiotic therapy or used short-term. But I'll show you some other research later in my presentation. It's probably one of my favorite probiotics to use. It's a transient non-pathogenic yeast, helps increase secretory IGA, and it also has benefits on the intestinal barrier function that traditional lactobacillus and bifido are not going to do. So, and you're never going to really have issues with adverse effects as far as bloating with that. So I typically do the antimicrobials for 4 weeks and then remove them. This test was done 3 weeks later. You can see everything from the dysbiosis to the pathogenic bacteria were gone, and the only thing that was present was the anti-gliadin antibody. So this could be due to cross-contamination, or as we know, many people that start a gluten-free diet, they end up having issues with, it takes them a while to figure out what they're eating. So based upon all her testing, everything came back pretty optimal. She had a significant improvement in her joint pain, and then we just continued the strict gluten-free diet, avoiding the processed foods, and then we continued some of the GI support. Now, obviously, I'm just giving you a short snapshot of how we initially started things. I mean, obviously, I'm going to work on other things later with nutrient status. I will say I've had a lot of patients over the years that react to gluten on the testing, and then when they go to the rheumatologist, it was interesting because probably like back in 2007, one of my like early patients that had rheumatoid arthritis, I went to the rheumatologist appointment, and because I was like, you're all excited about what you're doing, you want to show these doctors, and you want to try to have a relationship, and the doctor said, your patient doesn't have celiac. And I said, I know he doesn't have celiac. All I'm saying is when he ingests this protein, he's having an immune response or getting inflammation from this protein. That's it. And so, I've come to the conclusion early on that I'm not going to convince a lot of traditional doctors, and but the patients are obviously looking for these alternative approaches. So the second case we have is a patient with atypical lupus. She was previously diagnosed with an IgG deficiency. She was getting IVIG infusions, presents with itching. So just from the limited information you see here, when I think of dermatological type symptoms, I'm thinking gut dysfunction, migraines, previously diagnosed with chronic fatigue and fibromyalgia, and then she has hair loss. So and then I see that she's taking Synthroid, and so it's not so much, in my opinion, that the person has all these different problems and conditions. It's more of like there's this underlying immune dysfunction, and the Synthroid, she probably has Hashimoto's. So if we look at some of the previous lab testing, you can see the positive antibodies for Hashimoto's. She's got a functionally low vitamin D, and so this is typically what we're dealing with. People have more than just one issue that's going on. We did some comprehensive testing, and then you can see that we eliminate gluten, and until the food sensitivity came back. I had her complete a 7-day food diary because my initial intake forms only contain a food frequency questionnaire, so I usually add this separately. And I will say, like, my intake forms are around 25 pages. I send them to patients. We don't make an appointment until I get everything back first. That's how I know how and I have one page that's a readiness questionnaire. So I have patients that will get that 25 pages to me in an hour, and then I know that they're willing and they're motivated, and then I'm equally motivated to get them better. And then I have other patients that they get it to me 2 months later, then I know they're ready, and I have some that never get back to me, then I know I never wasted my time with them. So it's just easier to do that. And then I get 7-day food diaries on every single person because obviously their vision of health is much different than our vision. And then, so since she had a functionally low vitamin D, we started her with 10,000 IU a day. So anytime I have around a 35 level or less, I'll do 10,000. If you're looking at the Vitamin D Council's standards, it's usually 1,000 IU per 25 pounds of body weight. 5,000 IU is about the dose you can give with no issue with toxicity if you're not doing any testing. And I just want to point out, although I just list vitamin D here, every single vitamin D product I give a patient has vitamin K with it. And in my opinion, if you're not giving K with your D, it's like malpractice, essentially, because you need the K to prevent soft tissue calcification. And when I mean K, we're not talking about MK7, just because there's lots of studies on it, and it's a proprietary ingredient. I'm talking about K1 and MK4, because they're the two forms that are stored actually in the tissues. And I have studies that show MK7 or K1 is actually more efficacious than MK7. It's also important to know there's these strong interrelationships, not with just K and D, but there's probably 4 or 5 studies I found in the last few years that show a relationship with essential fatty acid levels, magnesium, and D levels. And so we have to optimize all 3 of these. And that's really, obviously you don't want to have these monotherapies, but we have to have this complete picture. So here was some of the additional labs I ran on her, since we had a lot to start with. She had some dyslipidemia type issues, nothing hugely significant other than that on that panel. We did a food sensitivity test, and you can see that she had some issues with dairy and egg, and Candida was high on the IgG at least. But I will say, when I do food panels, I only, for example, this test came back, and gluten wasn't really so much an issue here. But I'm going to make all my autoimmune patients still eliminate gluten. Because when you look at food panels, they're typically testing 2 proteins for each antigen or each food. So if you also look at these immunology labs, many of them will test 20 to 30 different peptides in gluten and wheat, and they're not going to typically react to the regular gliadin. And they're going to react to one of the other ones. And and I will mention too, I typically pre-screen people for like 5 or 10 minutes, and if they have an autoimmune issue, which is about 80% of the people that I see, I won't work with them if they're not willing to get off gluten, because then I look like I can't. Then your work looks like it's not really efficacious. And I'm not going to say going gluten-free is going to just be the end-all be-all, but it's just one part of the 5 other things that you may have to address with them. So looking at lupus, again, since I just put a study in here showing that there's dynamic, dysbiosis with lupus. I mean, we can find these with all the different studies, but in this case, they show low lactobacillus. They gave him lactobacillus and vitamin A that helped correct the dysbiosis. This individual had some low lactobacillus, Klebsiella, and you can see the secretory IGA is low. So one of the things I'll point out about secretory IGA, I see this low in like 90% of the stool tests that I run. Just because they have low IGA in the stool does not mean they have a true IGA deficiency, because the blood's more tightly regulated. So if you ran this in the blood, it's not really so much an issue. When you look at it in the intestinal tract, I mean, think about it. IGA is the first line of defense. It's non-specific. It lines your GI tract, your nasal passages, your respiratory passages. So what things can we do to increase secretory IGA? Glutamine, colostrum. We can give different types of probiotics, Sac Boulardii. And when you see some of these different bacteria that can be inflammatory or an autoimmune trigger, just because you see the Klebsiella high, sure, you want to get rid of it or you want to correct that dysbiosis, but that's not necessarily why that person has their autoimmune issue. So when we also look at here on her amino acid profile, she had a lot of plasma aminos in the low first quintile, and so we can consider a balanced essential amino acid blend initially, but what would cause this we could think about is maybe they're not eating enough protein, they could have hypochlorhydria, and so the whole goal of these tests is not just to do a test and treat the test, it's to looking at pattern analysis between the tests that you can do, and then look at the patient's symptom and try to figure out, or I should say their group of symptoms or their issues or health concerns, and see if it's something that you can kind of put together this puzzle. So, in this case, you also see the nutrient toxic elements. Her magnesium's functionally low as well as zinc. And so you can do a lot of these, obviously, through Quest and LabCorp as well. But, obviously, there are a lot of labs that are just measuring serum mag, and mag's only stored 1% in the serum. So if it's low in the serum, it's kind of like having an anemia because you have to wait so long before the deficiency is going to show. So one of the interesting things, too, and we're getting into the pattern analysis, is the importance of having a nutrient toxic elements panel together is because for example, if you have lower amounts of copper and selenium, even like iron, they share a lot of the same protein transporters as the heavy metals. So if you have a deficiency in any of those minerals, those cells are going to put more receptors out to bring in more of that nutrient. That's kind of like when someone has an iron deficiency anemia, they can actually absorb up to like 50% more iron in a deficient state. So if you're sharing the same protein transporters, then that person, now they're going to be more susceptible to heavy metals. So we can't just think about the nutrient deficiency to address what the nutrients do, but they also act as antioxidants and regulation of some of those heavy metals. And so obviously if you're looking at this just in the blood, that's going to give us a good screening tool for like circulation, but that doesn't really tell you what's in the tissue. If you're really trying to look at heavy metals from like a tissue burden, you're probably going to have to do a baseline 6-hour urine and a provoked challenge most likely. But this is good if someone has hypertension, some other issues that they're symptomatic for and it's coming in through their system. But you can also see she has glucose in the prediabetes range and her alkaline phosphatase is low. And so what could be a pattern here? Well, zinc is high, or I should say alkaline phosphatase has a lot of zinc-dependent, it's a zinc-dependent enzyme. So that could be part of the reason it's low. May not be, but just something to think about. And so I just put some of the studies that show those correlations with zinc and alkaline phos. Also could be associated with like contributing to her hypothyroidism. It could be associated with hair loss. May not be related at all. But these are just the things we want to go on these research dives a little bit, because essentially anytime I do something, I'm typically giving the patients, showing them the research, because I want them to be educated and I want them to be able to take control of their own health, and I want to educate them on the lab testing, because a lot of times they go to a traditional doctor and they have to just surrender their health and they have no ownership that they can do something and really control that. So also, again, you're going to find studies with vitamin D in every single condition essentially, but we got our vitamin D optimal to like 87. You'll see later I dropped the dose down a little bit just because I like to keep it in that like 50 to 70 range. And then if we look on the organic acid testing, you can see the D-lactate's a little high, but the TCA, the tricarballate, is actually outside of the 95th quintile. So one of the interesting things about this, for people that do a lot of testing, is we typically see TCA high with like high carbohydrate intake or dysbiosis, but it also has a high affinity for calcium, magnesium, and zinc. And if we go back, she has low zinc and mag. So if we correct the dysbiosis over time, they're not going to necessarily need that long-term zinc and mag support potentially. Probably the mag just because most people aren't getting adequate intake anyway. So in this case, you can see some of the stuff that we did. And when we look at glutamine, I mean, I'm probably doing anywhere from 5 to 20 grams with patients to support that. I mean, this is probably more supplements than I start with a lot of people. I try to limit it to like 3 to 5 things initially. But at the end of the day, some of these people are on a lot of medications when they start to see us. They're symptomatic. We're trying to get results in a somewhat timely manner. And when they're in any chronic disease state, they're going to have higher metabolic demands and nutrient needs. So they're in a crisis, essentially. So they're going to need a little bit more to start. And you can see in her follow-up labs, from a traditional perspective, we got her lipid panel normal. She didn't have any more issues with, the glucose came back to normal. Her antibodies were not positive, and I screened some other stuff that was negative as well. So it's just one of those things that I like to use the traditional labs that the traditional doctors are using, but then use the specialty labs to see where there's the dysfunction, and then you can kind of really have that targeted approach. The next case I want to cover, and this is probably one of my favorite cases, just because I had this young college student who was diagnosed with Crohn's. And so I had an opportunity to kind of treat someone at the start of the disease before things got more progressive, before they got put on biologics and all those other things. And the interesting thing is, her father was a VP for a pharmaceutical company. And he said he didn't want his daughter taking a biologic. And so he wanted to see what we can do. And like I always say, I never guarantee anyone that I can kind of fix what their issue is. But what I can guarantee every single patient that hasn't seen anyone for functional medicine before is I can take snapshots of their health that was not looked at before, and I can address some nutrient deficiencies and some things to get them to a better state than they are now. And as long as patients know that you care that way and you're going to do everything that you can, then they're going to typically be on board. And I'm not anti-working with the other practitioners because, like I said in the beginning, I'm not here to replace their specialist or primary care, and I'm sure they're not looking for that anyway. It's really to have an integrative approach and to work with these other practitioners to get the best clinical outcome. So she had a previous history of antibiotic treatment, which obviously we know is going to disrupt the microbiome. She had issues with acne and eczema, so I typically will think, gut dysfunction there. So here was a study that showed the impact of different antibiotics on the microbiome. And it showed that the oral microbiome was able to stabilize relatively quickly after antibiotics, but it took months and almost up to a year for the gut microbiome. So obviously there's a time and a place for antibiotics. I mean, if I had any issues with strep or some other conditions, obviously you have to take the antibiotic. But you can also mitigate that with sac boulardii and some other support. And we can't just think about nutritional therapeutics, but also lifestyle, right? So if people aren't getting adequate sleep, it doesn't matter what they have going on, it's going to exacerbate their issue. So I kind of just have that in there as a resource. So this is all I had on my first consult with this patient. So I met with her and her father. We went over this. And her high sensitivity CRP was 92.2. And she was in the hospital, and I said, what did they say about the anemia? And he said, surprisingly nothing. And I said, what did they say about the high CRP? And he said, surprisingly nothing. Now, I just want to say, the only reason they probably didn't say that is because they were planning on putting on a biologic and a lot of this stuff was going to get improved. But the point is, there's not really great communication. But when it comes to the anemia, I found this great study that showed how anemia is a recognized key of IBD, and how, if you look at the second area, although efficient therapeutic options have been developed for the treatment of IBD-associated anemia, treating anemia often has a low priority for GI docs. And that's exactly what we saw here. So no one ran an iron panel with ferritin. No one ran because if you just look here, the first thought I see is, if I look at the MCV, she's trending on the lower end. So I'm thinking maybe iron deficiency. Obviously anemia from chronic disease as well, or inflammation. So we ran some specialty labs. We added some additional testing. You can see her iron was low. And then, so here's the thing. She goes back to the GI doc and he says, your diet has nothing to do with why you have Crohn's, and nutrition has nothing to do with it, and was very dismissive. So what I did is I emailed him the study showing the micronutrient deficiencies in IBD, because I have a smart analytical guy that wants to see the research. And so we kind of just started from there. And so we did a stool panel. You can see, obviously, this is the typical pattern you see with a lot of people with IBD. Typically occult blood. You're going to see calprotectin elevated. EPX typically associated with food sensitivities. Probably the IGA is most likely either to dysbiosis, and then obviously low butyrate, short-chain fatty acids, etc. And so, although this is a great test, one of the only caveats I have with a test that combines culture and PCR is if you just look at the culture section here, lactobacillus shows no growth. If you look on the left side, lactobacillus is on the PCR is in the third quintile. So number one, that's going to be an explanation for the patient why you're telling them you're not giving them a lactobacillus. But if you can't contact the lab, they're going to say lactobacillus is hard to grow out. So, I tend to, like just the quantified PCR for that. But again, study on the dynamics of the gut microbiome and inflammatory bowel disease. As Dr. Brady mentioned yesterday, the adult microbiome is typically stable, but we see a lot of instability with a lot of these autoimmune conditions. So she had some low magnesium issues. You can see low vitamin D. So this is a true deficiency because she's below 30. And then this is just for your resources. This is 5 or 6 different studies on vitamin D and IBD. And then if we look at the bacterial metabolites, she definitely has some issues with the D-lactate. Some of those other markers at the top are more like phase 2 detoxification type markers. But then there's a lot of food sensitivities. So, I tend to use stuff more these days or more recently that does the intestinal permeability screen as well. But again, you have a starting point with what we can eliminate. So I typically always eliminate the moderate to severe food sensitivities. Now, that range is going to determine, that duration is going to probably determine on the severity. But, IgG reactions or those immune complexes take about 3 weeks to clear. So at a minimum, you're probably looking at a month. Some things may stick around a lot longer. It really kind of depends on the immune tolerance of the individual. But we did therapeutic doses of D, Mag. Now, I know there's controversy with iron in IBD. However, if someone's anemic, you still have to address it. And I honestly, in a patient like this, we're going to be retesting them regularly. So we can easily adjust that as we calm down the inflammation. And the other important thing is a lot of people that have issues with iron, it's because they're supplementing with the iron salts, that they compete with other nutrients for absorption. They cause GI symptoms, can cause constipation, where if you're using a chelated form of iron, it doesn't have to be several hundred milligrams like a salt is. And it's a lot more bioavailable, and you don't really have so much of those issues. Obviously, there are things that you can aid to increase iron absorption, such as like vitamin C, folate, B12. But I found just using the regular bisglycinate form to be efficacious. And then we used some different GI support. I mean, these are things that are your mucilaginous sluggish botanicals that are really going to plug up some of those receptors in the GI. Therapeutic doses of glutamine, and then we gave some sac-bilardi. I avoided the lactobacillus only because the D-lactate was creeping up. And then I just put a study in here for glutamine. That's just as a resource. But here's a great review on sac-bilardi for conditions. And this is what I was alluding to earlier in my presentation, is it's not just, there's so many good antimicrobial type properties with it, antitoxin properties, and you can see a whole list of acute and chronic conditions that have success with being treated with sac-bilardi. So it's a great therapy to use. I use it in a lot of these individuals. And you're going to get those other benefits on the intestinal barrier function. And now you can see she has an essential fatty acid, I would say, insufficiency, where it's not optimal. But because I have her on all this stuff to start, it's a priority to get the other stuff done first, in my opinion. And so I knew I was only going to be running these or having her take the antimicrobials for 4 weeks at high dose. So when she stops that after 4 weeks, that's when we add in the fish oil and some of the different enzymes that contain polyphenols and curcumin, et cetera, to help have an anti-inflammatory effect. So this is 2 months after we started. So you can see her CRP, her high sensitivity CRP dropped from 92 to 16. And so it's still high, obviously. We want that typically lower than 1. But they were satisfied enough with the change in 2 months to continue with what we're doing. And the only thing I'll point out here, that I didn't mention in the beginning, when we saw the high sensitivity CRP so high, most people think of that as like cardiovascular risk, et cetera. But on that one page I had, it shows when high sensitivity CRP is elevated at the time of diagnosis, it's an effective marker to use for disease severity. So what am I doing? I'm doing the specialty labs to look at the dysfunction. Then I'm doing the same labs that the doctor, so this is from the GI doc. So she's still seeing the GI doc to get these tested. And then if we look at, this was 2 months after care. 2 months later, the CRP, C-reactive protein, cardiac, or high sensitivity CRP, that's just how LabCorp lists it. But it's 1.66. Sed rate dropped to normal. We sent this to our GI doc, and he said it was a temporary phenomenon. So we continued. So we had a 10-month follow-up. Now we have her more on maintenance. So you can see the iron dose dropped 60%. We're doing more stuff from immune modulation. And you can see this is the following year. Again, iron's better, vitamin D is optimal, the inflammatory markers are normal. But now we're going to take it a step further because now I want to make sure that calprotectin stays normal because that's telling us the inflammation at the mucosal level, where instead of just looking at it in the blood. So that looks good. And then again, I can keep doing this, but I started working with her in 2015. I still work with her today, just maintaining things. She probably does a stool test, once to twice a year. She still sees her GI docs and has colonoscopies. So she's really just on a maintenance. She hasn't had to take any biologics. And, who knows? There may be a time and place if she changes her lifestyle, changes her diet, stops taking therapeutics, she could have some sort of exacerbation. But the challenge is a lot of these people don't know that they can do things to change the trajectory of that condition. So the last study, or the last patient that I want to cover is a 41-year-old female, complains of headaches, joint pain, bloating, fatigue, hives, restless leg syndrome. She was previously diagnosed with Hashimoto's. She had breast implants, and with medications, you can see just the limited information. My thought process when I see this, well, she has bloating, she has GI symptoms. That can be related to IBS. If she was previously diagnosed with autoimmunity, she probably has some maybe barrier-type issues. She has hives, so probably have some issues with GI. Restless leg could be iron, magnesium, some other types of nutrient deficiencies there. And then the medications, obviously, now you're giving things that are going to decrease stomach acid output, really just things for symptom management and disease maintenance. If we look at some of her previous labs, she had a high TSH even though she was on medication, some positive antibodies for Hashimoto's, some dyslipidemia, vitamin D deficiency, ANA is positive. So we did a stool test, bridged the gap with some of the other markers. We did food diary, strict gluten-free diet, therapeutic doses of D. So a lot of these things start off around the same, and then if I have to dig deeper in other areas, then I'll look in that direction. So you can see on her stool test, she had some low commensals, slight dysbiosis, but really nothing in the intestinal health markers. Now, if you have someone that has all this joint pain and all these other things going on, and I don't really see a whole lot, that slight dysbiosis and that little bit of that low commensals is not going to cause all those symptoms. So I had less likelihood to go after some of this. And even when I did some of the other markers, like her CRP looked good, homocysteine and vitamin D wasn't too bad. It wasn't optimal, but that wouldn't cause her to that therapeutic. Even the omega check. This is much higher than most of the patients that I see to start. So I was kind of thinking we didn't really identify what's going on. But anyway, We followed a strict gluten-free diet anyway to start, optimizing the stuff that we know we can do for autoimmune type things. And then I was kind of just thinking, like, what's going on with this patient? And then I was going back through her intake forms, and then I remember seeing that she had breast implants. And I asked her if she ever heard of Asia or breast implant illness. And we tried to get the timeline when she's had these done. And I'm like, I'm not sure if you have this, but I would go back to one of your traditional doctors and have them investigate this further, because the stuff that I found on this testing is not the reason you have this severe symptoms. I mean, no one should be walking around with a cane when they're 41 years old. So then she tells me how she since our last consultation, she was in and out of the ER to joint pain. She's not able to walk without a cane. She was tapering off prednisone, and she was going to have surgery. So the doctor she saw actually kind of agreed that this is most likely the issue. I mean, they can do certain tests for sensitivities to that type of thing, and they can look if there's any leaking with the capsule and things. But I wanted to put this case in here because this really isn't anything that I personally have done. It's more about the importance of the integrative approach and working with other doctors, because I couldn't fix this, and a lot of times at the end of the day, it's all about getting the patient better, and so it's really just opening their eyes to some things that some of these issues. So we're still supporting her. So, and this is just a study with Asia, and talking about some of the adjuvants and how they can cause some issues. So again, we're following gluten-free diet, but at the same time, she's having surgery to get her breast implants removed. So what can I do? I can still support her immune dysfunction, and then I can give her stuff post-surgery to help with healing. So we can give specific collagen peptides that have certain molecular weight to signal for those certain tissues. We can give glutamine, which is going to help with wound healing and obviously GI, and then NAC for detoxification. So it's just kind of really giving overall support where they're at and what they're doing. And then at the same standpoint, we kind of dug a little bit deeper into possibly food sensitivity type stuff. So again, she had some issues here with some certain foods. And then if you look at some of the labs, again, some of the autoimmune markers that were an issue before were not at the repeat testing. You can see the vitamin D moved up significantly, and the thyroid markers, TSH and all that, were optimal with the medication that she was taking. So, so the big thing here is, this is one of her last messages after she had the surgery and was doing this stuff. She was saying how, since she received the glutamine and the collagen, she eliminated all the foods, extremely eating much cleaner, and she felt good. A lot of these other symptoms were gone, and she had zero joint pain and inflammation. So it's one of those things we got to see where that patient is with what's going on, and sometimes it's going to take longer. If you see some of these cases. A lot of times when people have GI dysfunction, people think they can do a detox for 2 months, or they can do someone's gut protocol for 2 months, and it's going to heal their leaky gut. I can tell you right now, if you have antibodies to zonulin, actin, or LPS, it's going to take about 4 months of therapeutic GI support to see a change in those antibodies. So I know a lot of people like to do, protocols or some things to get people jump-started. But you have to understand, some of these people that have GI issues, they've had these things for years. And you can't expect it just to turn around in 2 months. And I've had people with Hashimoto's that has taken a year and a half to kind of get to a point where we wanted it to go. And then you're also going to have some people that are not going to be compliant, essentially. And we're here if and when they're ready, right? So the last thing that I kind of want to just leave everyone with is just this little cartoon. The doctor will be with you in a few minutes. He's trying to figure out what disease goes with your insurance, and the point here is the patients that I work with they have very good insurance, or they may have HSAs, but I still use client bill accounts with LabCorp and Quest and Cleveland Heart Lab because I don't want insurance to dictate what we order. If I want to repeat stuff in 2 or 3 months, we don't want to. I can tell you right now, if you want to look at homocysteine, homocysteine, and some of these other markers, they're going to be considered investigational by insurances. Or if you're looking at advanced lipid panels or oxidized LDL. So it's like, why get surprised by that when you can test, homocysteine for like $15 or vitamin D for $18? A lot of these things, if you're filling in the gaps with the traditional labs, it's relatively not that expensive to look at some of those other things, and then just start with maybe doing like one other specialty lab with the traditional labs, and then you have something to work on the next like 3 months. And then if you have to dig deeper or go further down that rabbit hole, you can. So I think I have a few minutes left, about 2 minutes. So if there's any questions, I can take some of those.
Yeah, hi, Anton Warner. Can you please address ingredients and food ingredients about lectins? Lectins are mostly in beans, and these lectins are basically major triggers of autoimmune system. There is an amazing program done by Dr. Jokers called Autoimmune Elimination Program. Yep. One of my family members, she is from South Asian community, and she had autoimmune disorder, rheumatoid arthritis. So we tried to eliminate the lectins diet, and it finally improved. And I would like to hear from you if you can address this issue with the lectins. What is your opinion on that?
No, people are definitely going to have those issues. I mean, there's a lot of different anti-nutrients and other things that are out there. Just the same way, like a lot of people tend to like avoid white rice, for example. I mean, it's a different topic, but people tend to avoid it because of the glycemic index compared to brown rice. But brown rice obviously can be harder to digest, and most people aren't going to eat it by itself, right? They're eating it with protein and other things that are going to kind of lower that glycemic load. But just like someone can have, I mean, here's the thing: what doesn't really matter what protein or food it is. People can have a reaction, a sensitivity or an issue with that, and there are labs that you can do just testing lectins in different parts of, different other grains, and so for sure, I mean. They tend to be harder to break down, and realistically, anything that we eat is foreign to the body, right? And so you're essentially, it goes for supplements too, right? There's things that people can react to. So we just have to be conscious of that, and I think the challenge is in today's day and age, people like there's like a tipping point where they have so much more toxicity than they had maybe like 15 years ago. So it's harder to get to some of this. And some of these people have chronic conditions for so much longer, and then by the time to see someone, it just takes that much longer to get them better. You still see improvements in a relatively short period of time, but to get more of a resolution. Any other questions?
Actually, this is kind of a very specific question, but I was just curious how you mentioned that when you were looking at tricarbonate. I guess that was in the urine analysis. Was that the urine analysis? Bacteria. So
it's a bacteria metabolite in the urine.
Okay, and you said you knew it had a high affinity for zinc and magnesium.
It has a high affinity for zinc, calcium, and magnesium.
So I was just wondering, how do you know that? I mean, I don't remember learning that anywhere. How do you get that information?
I mean, kind of the Bible of functional medicine or laboratory testing is like the Lord Braille book.
Yeah, I mean, I did.
There information's in that, and I know Dr. Lord, recently did a republication like in 2020 or 2021.
Yeah.
But if you want to email me or give me your card, I can always send you like the reference and where that is.
Yeah, actually, I do. I had the book. I did nutrition at Bridgeport.
Yeah.
I guess I missed that part. I was just thinking it's It's an awful lot to remember, and I guess you just go back and you reference, you look up.
Yeah, I mean, here's the thing: is like a lot of these things.
Yeah.
I mean, obviously, I know these because I did the cases, but
Yeah.
and I do a lot of teaching. But at the same standpoint, it's not like I don't ever open up these reference books, right? It's like we're never going to stop learning, right? We don't know everything, and,
Yeah.
a lot of times, like if you have something, you look at the pattern, and you're like, hey, I think it's this, and you go back to some of those books.
So I guess when it says an affinity, it means that the bacteria would use a lot of zinc and magnesium.
Yeah, well,
and
yeah, you're basically like binding it or preventing the absorption of it, so it can cause those nutrients to be more in a lower state, and so
because the bacteria use
correct.
them and they okay.
So you have to just so it's kind of looking at the whole pattern analysis there.
Okay.
And your second question?
Yeah, I had one more. So you mentioned challenging someone to get metals out,
Yep.
and I do have a general question about that. I remember learning that it's kind of dangerous sometimes.
Correct.
And so I've never personally done it. I don't know anyone I can recommend to have it done. If you need a patient or a client to have that done, who do you recommend them to? How do you go about
Well,
doing
I mean,
it?
here's the challenge. I mean, I think metals for at least me,
Yeah.
it's probably one of the last areas I'm looking. And, especially if you think about it, like it's probably not going to be an issue with younger people. Unless we know of a real exposure to it, right? So most people like 40 or older,
Mm-hmm.
if what you do is chelation, and you do a baseline and a provoked challenge with like a chelating agent like DMSA or something, I guarantee you every single one of us in our room is going to have a different baseline and post, and you're a candidate for it, right? So it really comes down to like you have to look at like, well, what are the symptoms and the issues the person are having? Can it be contributed to some of those heavy metals? And then try to reproduce that with some of the testing. So like to your point, like you're looking at different compartments. So like again, blood, current exposure. You can do hair testing,
Yeah.
but then you have to deal with like, fine, from a screening tool, it can be okay. But then like people use different hair products, there can be contamination of other things. It's very hard to determine if there's an issue with that. And then a lot of times when people do these detox programs where they think they're like detoxing them of metals, I mean, none of these natural agents are deep tissue chelators that's going to remove that out of there. I mean, the closest thing we have in the natural area is really like high-dose NAC. I mean, sure, you can take binders and other things, and there's other like natural things like like citrus pectin and chlorella and all those things. They're typically going to prevent the reuptake of the hepatorecirculation from like the stuff that's in the GI.
Well, that's why I thought it was dangerous.
But you're not going to necessarily get it outside of that. So, I mean, I guess what I'll say is, a lot of people that have intestinal barrier issues, they can have blood-brain barrier issues too. And if you start to do some therapeutic chelation with like a drug, you run the risk of like redepositing those in other areas. And so you have to really, it probably depends on, the individual and the severity. And they may be better off just not doing anything and just supporting like regular detox pathways, and then just trying to look at some other things as well.
Thank you.
Yep.
Hopefully a quick question for you. I've been hearing a lot of controversy about daily dosing of iron as opposed to every other day dosing of iron. Have a thought?
It doesn't really make a huge difference. I mean, if you look at the research, you can actually dose, because some people are sensitive, right? So you can actually dose iron like once a week. And it has pretty much the same effect on the CBC. One of the books we use at Bridgeport is Advancing Medicine with Health and Disease, and they talk about that whole thing in the iron deficiency anemia chapter, and so what happens is obviously from a compliance standpoint as well, you can just especially in deficiency states, right? You're going to have much more. You can absorb 50% up to 50% more, so you can just dose that. Once a week or a couple times a week, but I haven't had really an issue with it. And there's some people that I will, like especially when they're like after we gave them the iron for a while, and then like their inflammation's down and they don't need it as much anymore. Then I will dose it like maybe like 3 times a week.
Okay. And you don't find the iron's inflammatory, so that it might be better to.
Well,
not
I
dose
mean,
daily.
I will say, I mean, it can, but the bigger thing I think is it's not just these things we're just not blindly giving them, right? Like we're only giving like iron or copper or some of these nutrients when we have a confirmed deficiency on objective data, and then we're retesting it like 2 to 3 months later, so we're never really having that issue. But I mean, I can tell you right now, like there's tons of people I have with insulin resistance and other things, and typically older women, and I've been running iron panels in every one, and it's kind of scary with some of the, I see elevated ferritins all the time. Some of the stuff's inflammation, some of the stuff, I mean, I haven't, not necessarily hemochromatosis, but some of the people that just have higher saturations, I'm just telling them to donate blood, and if they can't do that, they can at least go to a place to get like a therapeutic phlebotomy.
Thank you.
Yep. Any other questions?